Kendra.
Thank you for that introduction. I appreciate it. As mentioned, I am a cardiac surgeon that also trained in interventional cardiology. And today I will be talking not about surgery. Here are my disclosures. So my images look very strange on my screen. I hope you can see them better there. I'm going to start with a case, a 65-year-old male with shortness of breath. He has a severely calcified valve, and as you can see, a elevated aortic valve area, a small aortic valve area, 0.73, an elevated mean gradient of almost 60, so severe aortic stenosis. He presented to our valve clinic to discuss TAVR versus SAVR, and so every patient starts with a CT scan, and this will be my one surgical pitch. I do believe that every patient, even those referred just to a cardiac surgeon, should have a CT first, so you understand the anatomy. Here you can see that his annulus measures 76 as perimeter. The area is 457 with an average diameter of 24. So presumably a 25 millimeter surgical valve, a 29 millimeter self-expanding valve, or a in between probably 26 millimeter interannular balloon expandable valve. No other features. When we look at the CT scan and we're planning for that first valve, one of the things we need to pay attention to is the sinus of Valsalva. And here he's got nice wide sinuses, but this does demonstrate that he is a bicuspid, which we kind of knew from his echocardiogram. But when I'm thinking about what valve I'm going to put first, I have to be thinking about what valve I'm going to put second. And that's going to be a talk later that I won't dive into, but I need to be thinking about it at this stage of the game. For his STJ and ascending aorta, no major features. The aorta is not dilated, does not require an intervention, and so thus surgery is not needed. Coronary heights and sinus heights adequate bilaterally, and common femoral arterial access is also appropriate. As we look at national trends, you saw this earlier, and my patient falls into this young age group, growing number of patients being treated with transcatheter therapies. We have no randomized data for TAVR versus SAVR in bicuspid aortic stenosis. You also heard this earlier this morning. However, there were registries within each of the low-risk trials that in carefully selected patients, the results are good and not different from the trileaflet valves for both valves, and registry data that further supports its use. So maybe this is a right first valve for this patient, a TAVR valve. That's what he wants. And as we know, the NOTION study is our only 10-year outlook. He's young. So if I extrapolate his pathology to from a trileaflet valve in almost 80-year-olds, is this the appropriate data for him? Well, it might be, but what it tells us, as we learned earlier this morning, that at 10 years there was no difference in mortality, no difference in the composite of mortality, stroke, or myocardial infarction, with some indication that structural valve deterioration was higher in the surgical arm. And if you look closely, you see at the beginning in that 0 to 1, a lot of this happened in that first year, suggesting the patients were implanted with small valves to begin with, because this definition of structural valve deterioration has to do with gradients on echo. If you put a small valve in to begin with, you cannot overcome that small valve. So as we looked at that CT scan initially, surgical valve would be pretty small for him. Interannular valve may also be small. Importantly, in this NOTION study, the bioprosthetic valve failure based on reintervention, death, severe structural valve deterioration, or aortic valve, I already mentioned aortic valve reintervention, was no different. So maybe TAVR is the right choice. Certainly, this durability data suggests there was no difference. As we looked to the two low-risk trials, this gives us some midterm, but not long-term. And my patient, who's 65, may have many valves in his lifetime. I would certainly presume at least 2. Primary endpoints at 5 years, death, stroke, or rehospitalization. For an intraannular valve, no difference. No difference also for a self-expanding valve, but this is only out to 4 years. Now, there are subtle differences in the percentages that I will not dive into at this point, but at this stage, what I can tell my patient is with the available data, and as a reminder, the partner study and the low-risk Evolute trials will provide us also the most data on randomized controlled patients in the surgical arm, because we didn't do those studies. And so we don't know what real durability is. So this gives me a good idea that durability is going to be appropriate no matter what this patient selects. So when we talk about optimizing the first valve, pre-dilation, post-dilation, fracture, all of these things have to be taken into consideration. But the planning starts with the initial CT. The planning doesn't start when the valve fails. So in this case of my gentleman, we did perform a pre-dilation with a 20 millimeter balloon. We then performed this in cusp overlap. I apologize for the images. They looked great earlier. In the cusp overlap view using the technique that was outlined in the Optimized Pro study. So positioning on the non-coronary cusp with the pigtail at the base of the leaflet, confirming our deployment position once we are at 80%, with the goal of the valve being at 3 millimeters. The new valve has gold markers, so the FX now makes this a little bit easier, but the range between 1 and 5 is really the goal. We then roll to the left, and I apologize for you not being able to see this well. As you saw from the right view, this was a very constrained valve. From the left view, this looked well expanded. So if you had used the Pro technique or the coplanar view, you would have thought this valve looked great. But in fact, when you saw it in the cusp overlap view, there was an incomplete expansion. So we did first assess the gradient across this valve, which was 12. And I think that we used to think 12 was a good number. Well, an underexpanded valve with a gradient of 12, clearly not a good result. Oh, there we go. Thank you for resetting that. And so we did perform a post-dilation. Whoops, let me go back one. So let me show you this now that I can see it, and I have a couple of extra minutes. Gold markers is noted there. Here's my underexpanded valve in the cusp overlap view, concerning. I roll left. My depth is about 3. Presumably will end up about 3 on the left as well. This is a Pro Plus valve. And so we do perform a post-dilation with a 23 millimeter balloon. The valve is going to move up as the nitinol expands. We based the balloon size on the waist of the evolute, and our final result is a mean gradient of 6 with no paravalvular leak. And what we thought was excellent position, an excellent position to set him up for a second valve. So 29 millimeter evolute, easily implanted in a bicuspid. You notice that the annulus appears circular. We do not perform routine CTs, but that would be one way to confirm that. Postoperative EKG shows no conduction abnormality. Here he is at 30 days. The gradient is now 4. There's no paravalvular leak, and he continues to do well. So this is what we're trying to avoid. I don't have a great summary for you, but this is what we can't accept anymore. You get one shot at the perfect first result. I know Raj showed you an example of using the first valve as an anchor for your second valve. That was not this case. That was not our plan going in. In fact, the image here is of an original Certavi patient. And at the time, this valve didn't leak. But from 2017 to 2021, you can see there was increased paravalvular leak and early structural valve deterioration, requiring a second valve inside of the first valve. In this case, we had plenty of room in the sinuses. We had no problems with coronary access or coronary obstruction. Of course, this patient is different than the bicuspid that I just showed you, but this is my take-home point. You get one shot at a perfect first result. Thank you.
Thank you, Kendra. We'll move to another surgical talk by one of our pioneers in the TAVR space, Vinny Bapat, who we all know from the Valve app that he has so helped us design and use over the years, but he's been a pioneer in so many of our interventions. He's the chief of cardiac surgery at Abbott Northwestern in Minneapolis, and is going to speak to us today about redo TAVR, an emerging epidemic.
Thank